Hi everyone, welcome to the class. And today we are going to discuss Odell cases, case number 38 and case number 41 as per the roster. So let's start screen sharing and start discussing the case. So the first case that we're going to discuss today is case number 38, advanced periodontitis. It is a severe periodontal condition here. I have chosen this case as a part of your lectures or part of your roster because periodontitis is an extremely important topic for the exam, and perio gets asked solely when asked in the paper 3 or paper 4 because this is easily diagnosed and easily identified. Any periodontal problem is first to be brought in the notice of a general dentist. And as a general dentist, it is your responsibility to understand the diagnostic criteria, the prognostic criteria, understanding the basic treatment, because you may be the one providing the initial conservative treatment and then knowing where to call in the specialist and send for the referral to a periodontist, and where the conservative treatment would be applied and where the surgical aspect would be applied. So these are the basic concepts of periodontitis that gets asked in the exam so many times. And yes, you can learn a lot from a textbook, from Carenza, from any perio book, but when it comes to clinically applying the knowledge and clinically knowing how should the management be performed for a patient with periodontal problem, and that's what ADC is exactly asking you. They'll give you clinical situations, attachment laws. They will ask you first about the classification, diagnosis, and then they will ask you about the management part. So in this chapter, you will learn beautifully about the diagnosis part, identifying part, and then also learning the surgical aspect, and then your conservative aspect, where to apply which aspect of treatment, and how to select the patient for a particular thing. And also a little bit, you will be also discussing the replacement options where you would be extracting teeth. Similarly, in the exam also, when the extractions or the hopeless teeth are extracted, the prosthodontics questions are also mixed up with perio. So that's how the ADC is framing questions these days. They are clubbing the different branches of dentistry. They're asking you multidisciplinary approaches, and they're asking you multidisciplinary SPQs. So not just you should be looking at the patient in terms of just one subject or one specialty, but rather as a whole. So if the patient loses out on a tooth, you would also think like a prosthodontist and as a periodontist. So that's how the questions are also being framed. So in this, in fact, is a beautiful case that will train you to actually apply the prosto and the perio concepts together, and also take a perio patient as a whole and discuss all the various diagnostics and treatment plan considerations with it, exactly how the exam would also be judging you on this. So please utilize this opportunity, utilize this case to completely understand in depth how it is. So it's about a 49-year-old woman who has periodontitis. Diagnose and plan the management of a condition. A patient complains of 2 loose upper back teeth, and the teeth feel fleetingly sensitive to hot and cold. So not just they are mobile, but they are also sensitive to hot and cold sometimes. She's an irregular dental attender at your practice and had seen your colleague 3 years ago prior to his retirement. The clinical notes show that he has diagnosed generalized severe chronic periodontitis and carried out a course of a non-surgical periodontal treatment for her. But the patient did not attend for a review appointment because of her busy work schedule. Despite the past treatment on presentation, several teeth are loose, and the patient reports dental sensitivity as well as occasional soreness when gums are inflamed. She also recalls having gum abscesses on at least 2 occasions in the past and being prescribed antibiotics. So to gather from this one is that she has been diagnosed as a periodontitis patient. She failed to follow up for the follow-up appointments, review appointments after a non-surgical conservative treatment. Then she has had multiple loose teeth, there is sensitivity, gums are inflamed, and then there have been gum abscesses or gingival abscesses developed as well. So pretty much it's a bad picture of periodontally speaking. Besides having all her third molars extracted, which were extracted from her 20 years ago, she cannot recall having any other extractions. The patient reports being fit and well, takes no medications, has no allergies, as revealed by her medical history questionnaire. So what additional specific questions will you ask the patient and why? So first you'll ask about the oral hygiene regime, because that's the most important in maintaining any non-conservative periodontal treatment therapy. Patient tells you that she cleans her teeth twice daily with an electric toothbrush. She uses floss on her anterior teeth every day and only occasionally on her molars and premolars, where access is more difficult. Then current or past smoking. So smoking increases the risk of periodontitis 5-fold. This patient has never smoked, so that is not a contributory factor here. Then presence of diabetes or any other condition which is causing her susceptibility to the infections, because we know that poorly controlled diabetes has a strong association with periodontitis. This is relatively severe periodontitis, and there's also a history of multiple abscesses. So these features do not necessarily indicate an underlying condition, but it would be worthwhile to exclude diabetes and ask the patient to see her doctor to be tested. Another feature that might suggest diabetes is rapid attachment loss within a short period in middle age, suggesting type 2 diabetes. Then there's family history of premature tooth loss, because some conditions, some periodontitis can also have familial tendencies, especially your aggressive periodontitis. Then stressful life, patients who cope poorly with stress are more likely to develop periodontitis. Upon external examination, you find that there is no lymph node involvement, the joint and mandible movements are all within limits. Internal examination reveals that other mucosa and soft tissues of the mouth are normal, except for a one buccal sinus which has been formed just anterior to upper right first premolar. All teeth, with the exception of the third molars, are present. All remaining molars, 2 premolars, contain small to medium-sized amalgam restorations. There is no caries that is present other than the perio problem and these amalgam restorations. So how will you assess the patient's periodontal health and oral hygiene? So on examination of the mouth, the inflammatory status of the gingival tissues should be assessed visually. So noting any redness, swelling, and increased inflammatory exudate. So let's talk about it like how it would be applied in the exam. In the exam, you're looking for these findings, which will give you an indication that whether the disease is an active state or it's already existing periodontitis which has been arrested and it's not further progressing. So any present redness, swelling, increased inflammatory exudate all indicates that it's gingivitis, inflammation is present. That means plaque is present, and plaque is a positive factor for your periodontitis. So it is an active condition. Then you also check for the plaque and calculus, and you can use various indices to estimate the amount of plaque and calculus. After the patient has rinsed her mouth using a probe, the operator examines each stained surface for plaque at a gingival margin. If plaque is found, then information is recorded on the form in the appropriate spaces. After all the teeth are examined and scored, index is calculated by dividing the number of plaque-containing surfaces. Of course, you do not have to memorize the indices here, but the point is to record the calculus and the plaque, because these are the primary etiological factors for the condition, and they would immediately indicate that the active disease or the disease progression is going on. So the measurement that form a full periodontal assessment, you should also assess for the periodontal conditions, which would be by probing depth, recession, mobility, and furcation involvement, which would give you the complete periodontal assessment. So probing depth and recession are measurements are made at 6 points around the circumference of a tooth. So measly, and then midpoint of the buccal surface, then distally on the buccal, and then similarly palatally also mesially, distally, and the midpoint of the palatal or the lingual surface. So these are the 6 points where the periodontal measurements are taken, the probing depths are taken. Probing depth is the measurement of the margin to the base of the pocket. Presence or absence of bleeding on probing should always be reported in conjunction to this pocket chart. The presence and extent of the calculus should also be noted, so that gives you an etiological factor. The distance from the CEJ to the gingival margin indicates the amount of recession. So if you have a root and if you have your margin below the CEJ, that means that would be your recession. So not just there is loss of attachment, but there's also recession. So probing depth is going to be normal here, but then there is attachment loss. So attachment loss is CEJ to the base of the sulcus, recession is CEJ to the crest of the margin, and probing depth is margin to the base of the sulcus. So understand that probing depth is just an indication of the sulcus depth. It can be less than your actual attachment loss if it's your recession. So recession should also must be reported for, right? Then measurements are described in the table found for this patient. Clinical photographs and results of these examinations are also shown respectively. The patient's clinical appearance is not immediately suggestive of severe problem, and the relatively minor amount of visible plaque and gingival inflammation, they appear disproportionate to the extensive amount of clinical attachment loss. This highlights the patient's susceptibility to periodontitis and the importance of periodontal screening and subsequent comprehensive clinical assessment. Molar, upper left first, premolar. So these are the teeth where gingival inflammation is also marked. Furthermore, the loss of papilla between the upper incisors could be indicative of previously treated periodontitis. So these are the measurements. When you take them, what do they mean? So let's see of each score. This is applicable and this is really valuable for you to learn and apply that in the exam. So let's see what you can gather from each score or each value and what would be the significance clinically. So a pocket depth which is 0 to 3 millimeters, it's a normal sulcus depth. It's normal range. There's no clinical attachment loss here. Yes, unless there's no recession. So when your sulcus or junctional epithelium lies at the CEJ, then 0 to 3 millimeter pocket depth is normal range. But if your sulcus is apical to the CEJ and then the probing depth is 0 to 3 mm, then there is definitely your attachment loss. So this is your pocket depth given that the base of the sulcus is still at your lead, the CEJ. Then 4 to 5 millimeter mostly reflects that now the sulcus base has moved apically and it would indicate mild to moderate periodontitis. 6 millimeter or more periodontal pocket depth would indicate that the sulcus base has moved far more apically and has severe or very severe periodontitis. So for a mild to moderate, conservative periodontal therapy may be indicated. For a severe pocket depth, usually the first management would be a non-surgical management, but then later on in addition, surgical therapy may be needed, right? Then in case of recession, it indicates attachment loss, which is caused by past disease. Now the pocket depth has been shrunk, so the root surface gets exposed. It is still important to record in addition to probing depth to assess the true extent of periodontal tissue loss. As I said, that the probing depth is not always the accurate predictor of the attachment loss. Sometimes it can be added with the recession and the overall attachment loss would be greater. Bleeding on probing, if absent, it indicates it's an inactive site and periodontitis progression would be unlikely here because plaque is absent. And if bleeding on probing is present, that indicates there is gingivitis, there has to be primary etiological factor. It is an active inflammation, but not necessarily indicative of disease progression. And please notice that in smokers, bleeding can be masked and reduced, and the disease activity may also be higher than what would be clinically expected because the smoking has vasoconstrictive properties and it leads to your vasoconstriction of the blood vessels, leading to reduced bleeding on probing. Then tooth mobility, degree 1, 2, and 3. If the movement is between 0.2 to 1 mm in horizontal direction, it's minor movement, possibly physiological. If periodontal disease is present, conservative treatment can arrest it. If degree 2 is present, 1 mm or more, then it is caused by loss of attachment. Degree of mobility depends on remaining periodontal support and the shape of the roots. So the conical roots are more likely to develop mobility than your divergent roots. Then degree 3 is movement of the crown in a vertical and horizontal both dimensions. It indicates bone loss below the apex, also peripically the bone loss has also occurred, and little or no bony support usually would indicate extraction need. Going to the furcation involvement, so degree 1, 2, and 3, horizontal loss of supporting tissues not exceeding 1/3 of the width of the tooth, then horizontal loss of the supporting tissues in the furcation exceeding 1/3 but not through and through lesion, and then degree 3 is complete through and through. A probe passes from one part of the furcation to and comes out through the other. So this one is your early furcation, can be treated effectively in long term with a conservative non-surgical management, predisposes to further and more rapid attachment loss if you leave it untreated. Degree 2 is much more difficult to keep clean, unlikely to respond to conservative treatment alone. And degree 3 may be easier to clean depending on the soft tissue contour. Prognosis for the tooth would depend on the location of the involvement, the remaining amount of periodontal attachment, and the length and the shape of the roots. It indicates susceptibility to furcation caries and also involves loss or vitality of the root because if the root gets exposed, the accessory canals get exposed, and the secondary endo condition can also develop due to periodontal involvement. So these are your periodontal measurements that you would be taking: probing depth, bleeding present or not, mobility, and then your furcation involvements. So clinically speaking and clinically viewing this, it appears that it may not be as destruction, it may not be as periodontally involved. Interdental papilla is lost between the central incisors as we read. Plaque is evident at certain places but is not correlating with the amount of attachment loss. And these are your amalgam restorations. So there is inflammation with your left premolar, also your right first molar specifically. So going back, what are the other investigations that you would perform after your clinical assessment of periodontal tissues? So what radiographs would you take and why? So let's go to this table. So these are the radiographs that may be required. IOPAs using your paralleling technique, OPG, and vertical bite wings. So IOPAs are excellent detail for assessing bone loss, root anatomy, and periapical regions if taken with a paralleling technique. Selected views based on presence of clinical attachment loss are justifiable, necessary for this case to provide appropriate care planning. Disadvantage would be because your paralleling technique requires complete mouth opening and a deep placement into the periapical area involvement. So in patients who have tori or gag or limited mouth opening, it might be difficult to tolerate the paralleling technique. When OPG can be used initially as a general survey for a new patient, may also involve lower doses compared to a large number of periapical zones, especially those minimized by excluding your parietal and TM joint regions. But the disadvantage is that it's not as accurate, it's distorted, and it gives you doesn't give you as much detailed periodontal bone support or root anatomy or caries, and restorative status also is difficult to be estimated, especially around the anteriors, because that falls out of focal trough and can also be masked by your cervical vertebra. So then vertical bite wings, they are an option for molars and premolars when there is no more than moderate bone loss, and that helps because when you take bite wings, you are actually assessing the upper and the lower quadrants together. Again, helps you save the radiation exposure, but that's only indicative in the early diagnostic cases and where there's not more than moderate bone loss. And so that's why it might be helpful in the mild to moderate cases in earlier disease diagnosis. It cannot record proportion of bone loss because the apical regions are not visible. So you don't know what is the total proportion of the bone loss because you can't see the complete length of the interdental bone. Then less useful for diagnosis and monitoring compared with your periapical views. So most beneficial, especially in severe cases, is your IOPAs done with your barreling technique. So going back to what are the investigations and if the investigations were performed, what did you find? So selected periapical radiographs were taken as in the picture. What do you see? So the radiographs show widespread bone loss extending to and beyond the middle or apical third of roots of most teeth, correlating with the deep probing depths. There is angular infrabony defects and which are also associated with upper second molar, upper right first premolar, upper right canine, upper left lateral, or lower molars. These are interspersed with areas of moderate horizontal bone loss. So there's both kind of bone loss going on here. The angular or the vertical bone loss along with the horizontal bone loss, because there may be also because deep pockets lead to food impaction. So periodontitis gives you horizontal bone loss, whereas your food impaction gives you vertical bone loss. So because deep pockets lead to food impaction, so both kinds of bone losses are seen here. Furcation bone loss is associated with all upper molar and lower right molar teeth. Periapical radiolucencies are associated with the upper right first molar and upper left first premolar. Full mouth IOPAs were also taken 4 years back, as shown in the next picture. What differences can you see between the two? So bone loss is less severe in the 4 years back radiograph. Now there has been a rapid progression in multiple areas within a relatively short period. So what further examination or investigation would you perform? You would also test the teeth for vitality tests because there is severe attachment loss, and that could involve accessory nerves, accessory pulp canals, and can lead to pulp involvement. So this will include especially your all molars, upper right canine and the first premolar, which have excessive bone loss and root is exposed there, and the upper left lateral and the first premolar as well. Are there any other investigations necessary? Well, yes, the patient should be advised to see their general medical practitioner to exclude diabetes because we also have the history of abscesses that can also be correlating with your diabetes. At a later appointment, she reported that the diabetes test result was negative. So what is your diagnosis? Let's also look at the radiographs first and then we'll come to the diagnosis part. So this was the clinical appearance, and going to your probing depths. These are all highlighted in yellow are your deep probing depths. Show severe attachment loss. All are greater than 6 here. So these are your radiographic views. These are at presentation 38.4, and this is 4 years back. So if you look at the bone levels between the molars and premolars, it was also having some intrabony defects, but not to that extent. Central incisors, where the papilla is also lost, premolars and molars. There's also some amount of furcation involvement, the radiolucency at least, if not complete bone loss. Now at the present, see the increase in the extent of furcation involvement now. And this is typical maxillary view, maxillary molar appearance, the J-shaped appearance when the furcation gets involved. Similarly, look at the amount of bone loss progression. It has definitely gone deeper and more severe. You see the angular defect also. You see there's supra bony pocket or the horizontal bone loss as well, along with angular defects. With the lateral, it's severe. So it's correlating with what has been mentioned. For exam, it would be sufficient if you just look at the radiograph, look at the probing depth. You don't even have to look at the individual findings, individual value of the probing depth. If you look at it, most of them are more than 6. So that's your severe periodontitis, and more than 30% of the site getting involved. It's your generalized severe periodontitis, which was the correct diagnosis even previously made by the previous dentist. So under the previous periodontal disease classification, where you would actually give it based on the localized or generalized, if more than 30% site gets involved, it is generalized. Less than 30% is localized. Then severe because the attachment loss is severe, and chronic periodontitis. Then additional diagnoses include endodontic periodontal lesions of the upper right first molar, upper left first premolar, and lower left second molar. So these are endodontically involved as well. Periodontal disease classification system has now been revised since 2017, and the staging and the grading of periodontitis is now given just like in your oncology. So stage tells you how severe the condition is at present, and grade is how rapidly it is progressing. So these are the two basic criteria of classification now: staging and grading. Staging is about how severe, mild, or moderate. Grading is about is it rapid or is it slowly progressing. So not just the staging is important, but rather knowing with what grade or with what rate it is progressing. That's also extremely important in understanding the prognosis and the treatment planning. So the system has been simplified by British Society. Staging of periodontitis reflects the severity and the extent, and it's based on the radiographic bone loss. Periodontitis should also now be graded to estimate a future risk of disease progression and responsiveness to standard management. So please, in the exam, if you get asked, what does staging depict? It indicates how much the loss has been happened till now. And what does grading suggest? It suggests how much rapidly the progression of the disease is expected in the future. So one is the current indicator, past and present, and the other is the future predictor. If previous radiographs are not available to assess the rapidity of the bone destruction, then you use your method of how much the bone loss has been taken place and what is the age of the patient. Based on the age of the patient, if there's severe bone loss, then it's rapidly progressing. And if the patient's age is older and attachment loss is lesser, then it's slowly progressing. So simple common sense, if a young person has a lot of attachment loss, then it's rapidly progressing. And if it's an old person having less bone loss, then it's a slowly progressing disease, right? But in this case, you had an old radiograph, you have that suggester of what was present 5 years and what present now. So as you can actually see from the past and the present radiograph, you can predict it that it's a rapidly progressing disease. So in this case, because previous radiographs were available, it shows the evidence of rapid destruction. Calculating the ratio was not necessary by the age, and when known risk factors are also present, like your smoking and diabetes. So they are now highlighted to support the diagnosis. So in this case, both these risk factors are missing, and in this case would therefore be classified as generalized because, of course, the number of site criteria is same, greater than 30% is generalized. It is stage 4, grade C, currently unstable because there are pockets which are deeper than 4 mm with bleeding on probic present. And let's see how do you categorize it. So let's see, staging is stage 1, 2, 3, and 4, early, mild, moderate, severe, very severe correspondingly. Interproximal bone loss, if it's less than 15% or 2 millimeters, it's your early. If it's moderate, then it's up to the oral third of the root. In severe, it goes up to the middle third of the root, and in very severe, it goes to the apical third of the root, the interdental bone loss. Then extent, if it's involving only up to 30% of teeth, then localized. If it's more than 30% of the present teeth, then generalized. Then grading would be if the percent bone loss by age is less than 0.5%, then it's slow progressing, 0.5 to 1% is moderate, greater than 1 is rapid. So in this case, it is rapidly progressing, grade C. Then based on the stability of treated periodontitis, that whether you have successfully treated the previous periodontitis, whether the existing situation is stable or the patient is in remission. So if probing attachment loss is present, if it's still present, it could be still stable. It could be a previously attachment loss. In the remission period also, there would be still attachment loss. Probing that new sites would not be more than 4 millimeters. If there were deeper pockets now, they would have been reduced in size. It would be less than 4 mm, but no site should be greater than 4 mm with bleeding on probing. In less than 10% of the sites, bleeding of the probing should be present. In remission, more than 10% of sites will show you bleeding on probing. Radiological bone loss is present in both. In this case, because deeper pockets are present with bleeding on probing, already inflammation already present, it is in the state of remission. Previous therapy has failed. It is a rapidly progressing and active unstable periodontitis. Now, this patient has many teeth with furcation involvement. What are the possible sequelae? So, further and more rapid periodontal destruction, devitalization of the tooth as the attachment loss continues to progress, more accessory canals get involved, and more vitality may be lost. Periodontal abscesses can get formed because of the obstruction of the pocket. Root caries can develop because now the calculus and the plaque is on the surface of the root. So, this patient has already had non-surgical periodontal treatment. Why has the disease progressed still? So, although her oral hygiene was fair because of her susceptibility to periodontitis, further improvement is still necessary to achieve an excellent standard. Ideally, a full mouth plaque score should be less than 10%, and to ensure that this is maintained meticulously as well. Interdental spaces are more effectively cleaned when you use interdental brushes, and floss should only be used in spaces where they do not fit. Resolution of pocketing where an angular pattern of bone loss with non-surgical treatment is also more challenging, and multi-rooted teeth also may present inaccessible furcations. With improvement of oral hygiene, surgical intervention is a management option to reduce probing depths. In her case, with severe attachment loss, after reinforcing correct oral hygiene measures, after performing a conservative non-surgical treatment for her, if she continues to display a meticulous oral hygiene practice and it has started to respond to the non-surgical treatment modality, then the surgical aspect may also be considered. Patient is also an irregular attender. Importance of her role in controlling the condition must be clearly communicated to her because there is no cure for periodontitis other than extraction. The patient should be advised at the outset that she will need to commit to maintaining excellent oral hygiene and attending the clinic regularly for necessary, active, and supportive periodontal therapy for an indefinite period. The patient's responsibility in the long-term management of this condition should be clearly discussed prior to taking any treatment and should be documented carefully in the patient's records. Extraction of the teeth with a hopeless prognosis should be advised. Which teeth would you advise to be extracted now? So the teeth which have endodontic and periodontal lesions require extraction because devitalization has occurred as a result of progression of periodontitis rather than endodontic failure. Further restorative treatment is highly unpredictable and likely to fail. The upper second molars have minimal bone support. Unfavorable root morphology will make treatment difficult. Therefore, extraction must be considered. Extensive bone loss around the distal root involving the interradicular region is compromising the lower left first molar. The lower right first and second molars have angular bone loss distally. Poor prognosis may require extraction in the long term. So, however, all the molars are in occlusion and functional, with the exception of the upper right first molar. The molars could be preserved in the short or medium term. A definitive decision on extraction could be delayed until an attempt has been made to improve the periodontal condition of these teeth. If these extractions are carried out, the patient has to accept a premolar to premolar occlusion or a prosthesis. Patient did not wish to have any teeth extracted and accepted a plan to help retain a completely natural condition for as long as possible. All molars will be retained for the time being. The risk of further bone loss potentially affecting the adjacent teeth and the development of pain and abscesses should be clearly communicated to the patient and also must be documented. At this stage, what are your treatment goals? So, improvement of the periodontal condition of the teeth that do not have a hopeless prognosis. So, eliminate the suppuration, reduce bleeding on probing, reduce the pocket depth to below 5 mm, establish and facilitate maintenance of periodontal health with the aim of preserving as many teeth as possible and to prevent a premolar to premolar occlusion for the time being. Removal of the teeth with a hopeless prognosis and any necessary replacement if the patient agrees. A premolar to premolar occlusion provides acceptable function, although appearance may be unacceptable because the molar spaces will show and smiling depending upon the visibility. The upper second molars provide useful occlusion and although compromised can last for many years even with your conservative treatment. So what treatment you should be providing initially? Because of the presence of plaque, palpable subgingival calculus and inflammation, further non-surgical periodontal treatment was provided as described below. Prior to provision of the treatment, the benefits and the potential side effects were communicated to the patient and it was also documented in your notes, in particular the possibility of dentin sensitivity, recession affecting appearance and increased root travel. So given the oral hygiene advice, the patient was disclosed using a plaque disclosing agent, suboptimal plaque score was revealed, and that was 25%. Toothbrushing technique was checked, modified to ensure that the gingiva adjacent to the palatal aspect of upper teeth and lingual aspect of molars were also covered. Interdental brushing technique was also checked, modified so that the larger sizes were used in the upper interproximal areas and the importance of daily use was also reinforced. Oral hygiene was reviewed and found to have improved and the total plaque dropped again. Supragingival instrumentation and root surface debridement of all the quadrants were carried out using ultrasonic and hand instruments under local anesthesia over 2 visits. Oral hygiene instructions were reinforced. Now this option is going to be in so many questions in the exam. What treatment plan do you suggest to the patient? And this is your option that may be the answer for most of the conditions. Even when the patient comes with severe periodontitis condition to you like this, you have to start with the conservative management, intervene with the oral hygiene practices, administer the conservative treatment, and the conservative treatment is supragingival, scaling, root planing, root surface debridement, all the quadrants. Maybe you have to use local anesthesia and don't do it in a single appointment. So this is the key management, key role of a general dentist, how you would be providing the conservative treatment. This is your eureka moment that yes, in the exam, I've been given this option. And then there are like immediately refer to periodontist and advise the surgical management. No, you should first intervene on your own and do the number 2 for this patient and then see how he's responding. And then if the plaque is maintained and the oral hygiene practices are being done, then the surgical part can be started up with the involvement of the periodontist. Reassessment performed with full 6-point pocket charting 2 to 3 months after completion of root surface rewrite. Again, important. In 2 to 3 months, or you can say in 8 to 12 weeks, you are assessing the soft tissues again, and so root surface evaluation is also performed again. Patient maintained a more effective cleaning regime over the period of 3 months. Suppuration eliminated. Residual pocketing with bleeding was still present, especially in the regions with angular defects. And we've just talked about it. With the angular defects, the food impaction is going to be more complicated, and you cannot expect the angular bone healing with just non-surgical management because it's not soft tissue healing. So you may require that your guided tissue regeneration, so regeneration surgical techniques would be required. Conservative management was successful in limited areas because the patient's oral hygiene was good. More complex treatment and specialist referral were now considered. After the conservative management, after the patient's response and also involvement and commitment, then yes, the specialist referral would be involved. Then there would be cost implication when you go for a specialist treatment and you want regenerative therapies. There would be discomfort from the surgery. All that must be advised and warned. The patient must be warned of all that. The patient opted for specialist referral and had successful regenerative periodontal surgery carried out in the upper anterior and lower right molar regions. She also returned for extraction of the upper right first molar and the upper left first premolar, and an immediate partial denture was given. So 2 extractions were done for her: right first molar in upper and left first premolar. And then an immediate RPD was given to her for a temporary time being. So what are long-term prosthetic options for her? We're going to discuss that. As I told you, it's multidisciplinary. They may ask you the prosthetic component as well in the exam. What is the appropriate solution for this patient? So patient-centered decision-making requires the patient's views to be carefully taken into account and is crucial for effective treatment planning. The patient disliked wearing a removable prosthesis, did not want another one because of the low biological effect and cost. She elected to have a cantilever, that means one abutment only, and raise and retained bridge. So minimally prepared Maryland bridge, raise and retained bridge, which is only taking abutment from one side, it is cantilevered to replace the upper left first premolar. But after considering the advantages and disadvantages of the options above, which I'm just going to discuss, she did not get any replacement for the upper right first molar, only got a replacement for the premolar. And the specialist also reported that because of the extensive bone loss around the distal root, the lower left first molar was beyond saving with conventional or even with regenerative surgical treatment. So extraction would be required, or some treatment would be required for the lower molar as well. Let's look at the prosto options like the first premolar and the molar spaces in the upper area. So either you go with a definite or long-term acrylic partial denture. Well, advantage would be that other teeth, if they get also extracted because of poor prognosis, they can be added to this acrylic denture. It will have good appearance because acrylic can mask the soft tissues. But disadvantage is that it predisposes to increased plaque retention, leading to further deterioration of periodontal tissues, and it's also removable. Then you can go with a permanent or a definitive cobalt chrome or metal-based RPD. Well, it would have less plaque retention than acrylic, and it would be better tolerated with greater tooth bone support. But it is costly, and it cannot add more teeth if they're lost, and it is still prone to plaque retention, if not as much as your acrylic. And again, it is removable. Then conventional bridge, fixed, good long-term survival, but then it devitalizes the abutment tooth. It is biologically expensive because you have to chop off your adjacent teeth. Oral hygiene is compromised if pontic is poorly designed. Difficult to manage if complications or failure arise. It would need abutment teeth with good support. Upper right 6 requires a fixed design, so minimal support and resistant pocketing on the upper 7 excludes this option because the abutment teeth is not healthy. Then cantilevered, minimally retained or minimally prepared, raised and retained adhesive bridge. Well, that would be fixed. That's an advantage. No or minimal preparation. Minimal or shallow guidance on the abutment teeth, and easier to manage with failure. They will compromise the oral hygiene if the pontic is poorly designed. They would need sufficient enamel on the abutment tooth for the good bone strength. Cantilever design is not ideal for wide spaces and do not survive as long as your fixed design would. Then implant retained crowns, it is fixed, adjacent teeth are not affected, but there is increased risk of periodontitis where the patient already has existing periodontitis. Bone grafting, sinus lifting may also be required, expensive, would require careful monitoring and maintenance. Or no replacement at all, it would be low cost, maintain access for oral hygiene of adjacent teeth, but yes, it affects the aesthetics, especially in the upper left premolar space. Patient may experience impairment of function, over-erupting of opposing teeth, tilting of adjacent teeth. So all those options were given to her. She went for a cantilever, raise and retained replacement for the upper left premolar and no replacement for the upper right molar. Then something had to be done for her lower molar as well, because the specialist said that no conservative or surgical treatment can prevent that distal bone loss, furcation involvement around the distal root. So the treatment options given to her were either extraction or a non-surgical or a surgical management. So extraction was with replacement options similar to the upper teeth. Indications would be for very mobile, poor oral hygiene or compliance, patient wants extraction, there's caries infiltration, or any other reason which leaves the tooth unrestorable. Insufficient bone support on either root to conserve. Well, this option has been discussed and rejected. She doesn't want extraction. She wanted to be preserved. So non-surgical management would be continue your regular supportive therapy, root surface debridement, but it only works for grade 1 furcation involvement, and it is inappropriate in this case where furcation cannot be debrided without raising a flap. Then the surgical management would be tunnel preparation, RCT and hemisection, or RCT and root resection. So tunnel preparation needs sufficient residual bone around all the roots. It is not present in this case. Definitely the distal bone, the distal root has complete absence of bone support, and it helps in creating a furcation. It opens up the furcation between the roots. It makes it a cleansable area. So you reduce the amount of bone, but sufficient bone must remain for both the roots. It is not present here. So you would rather go for hemisection, removing half of the crown along with the root, or root resection where you only remove the root and not the crown. So hemisection is a difficult procedure and expensive. You hemisect the tooth, it loses contact on one side, and you would give full coverage restoration after giving RCT treatment. It is only suitable for teeth with bone far enough below the furcation to allow surgical access. Root resection, simpler than hemisection. It is expensive. Full coverage crown would be required because the fracture risk is associated with RCT. Only suitable for teeth where the bone has gone below to a certain extent, where you get surgical access and can remove the root without eliminating the crown from top. And so what are the treatment options for the lower left first molar? These were these. Root canal treatment and distal root resection were performed on the lower left first molar. So you did an RCT and only the root resection was performed, not the hemisection. This eliminated the furcation, enabled the patient to use a large incremental brush in the area. Inflammation associated with the mesial root also resolved. So does hemisection or root resected tooth require restoration? Well, yes, the large area of the exposed dead teeth and the risk of the fracture of the overhanging crown after you have eliminated the root will require a full coverage crown. However, complex and expensive treatment should be avoided because these teeth come with compromised prognosis. Only the teeth which have remained stable for months or years would be crowned or restored. The tooth remains in function and is an excellent semi-permanent solution to this patient's problem. Root treatment, surgery, restoration, and maintenance, they all add up to huge investment in time and money spent on just one compromised tooth. and the option of extraction and the potential prosthodontic replacement should be carefully discussed with the patient and documented. After completion of the periodontal and then restorative periodontal treatment, patient is receiving an ongoing 3-monthly supportive periodontal therapy treatment to maintain the improvements which have now been made in her periodontal condition and to reduce the risk of relapse. Medical legally, it is important to keep a detailed note of all discussions regarding diagnosis, management options, and also your treatments which are carried out. It should be ensured that the patient clearly understands the significance of periodontitis and the critical role they play in managing it on a regular basis, especially in relation to plaque control, smoking cessation, and diabetes control. Adequate notes, detailed advice given at each appointment should be kept in the records. Patients should also be advised of likely consequences if treatment advice is ignored. So this is after the treatment with root resection. So here only this portion of the root was removed and not the crown. It was not hemisection, but rather root resection performed. The mesial root initially had inflammation, now which has also subsided. Inflammation has also subsided. So this is the distal root, which is eliminated. You can see there was already no existing bone support to it. And that would be the end of this periodontitis case. I hope you gathered a lot of information regarding first the assessment, the periodontal assessment, coming to a diagnosis, knowing the staging, the grading, the stability of the treatment, and then planning the treatment, doing a conservative treatment first, engaging the patient, getting them trained for oral hygiene, making sure they're committing to the treatment. Then you discuss that later on, after all that has been achieved and the disease has been brought in control, then only the specialist referral is made. And then also understanding the prosthodontic options for the patient for the replacement, and then the surgical management or the root resection technique for the severe grade 3 for patient involvement. So many aspects of periodontitis have been covered in this case. It was a long 10-page chapter, but extremely beneficial, extremely informative. And trust me, 70% of your perio-related questions are going to be answered from this chapter alone. So that's huge. Please utilize this opportunity and try to imbibe this information as much as deeply as possible. All right, so on this note, we'll start with the next case for today's class, which is case number 41. Beautiful case about pemphigoid. We've been doing about blisters, vesicles, ulcers. Again, another important case. Here we learn how to diagnose and identify pemphigoid. And yet again, let me just emphasize over it again. Pemphigoid, pemphigus, lichen planus, leukoplakias, other vesicle and plaque type condition in the mouth. Repeatedly, multiple times getting asked in the exam. So there is no denying and no escape from these concepts. Please master them. Please go through them again and again until the time you have mastered them. You just close your eyes. Anybody asks you any questions regarding any blister, any vesicular, any ulcerative condition, and your answer should be immediately to your tips and to your memory. That's how well you should understand these conditions. Been spending so much time in discussing and comparing and drawing contrast between these conditions. This is yet another opportunity to learn about one more condition, and I hope it will help you even more. So let's start discussing this as well today. This is the second case from today's class. So summary of the case is 63-year-old female patient of your general dental practice reports severe oral discomfort with blistering. Identify the cause, outline the appropriate management. This is a clinical occurrence of gingiva. As you can see, there is greater involvement of entire attached gingiva here. This situation as well. It is progressing deeply to entire attached gingiva. Denuded shiny appearance of gingiva. The patient complains of soreness involving the cheeks, gums, and palate, which started 12 months ago and has increased in severity since. The blisters which form that burst to release a clear fluid. She's able to tolerate soft foods in her diet, but avoids anything hard or sharp, as even minor trauma can cause a blister to burst. When a blister bursts, it leaves a painful ulcer, which is very slow to heal, and brushing of teeth is painful and associated with bleeding. Denies any cutaneous or genital blisters. History is negative for dysphagia or odynophagia. Dysphagia is difficult swallowing. Odynophagia is painful swallowing. However, she describes recurrent nosebleeds and nasal crusting as well. No eyes or ocular symptoms. Only relevant past medical history is hypertension, for which she takes Ramipril. External exam is unremarkable with no cervical lymphadenopathy. Eyes are also normal. Appearance of the gingiva as seen in the picture demonstrates extensive gingival erythema of the buccal and the labial gingiva in all the quadrants. There are ulcers on the posterior gingiva on the right side. Inflammation is generally limited to the attached gingiva but extends onto the alveolar mucosa and into the sulci in several places. Which diseases cause oral blistering and how do these blisters form? Let's go to the table and see what conditions can lead to blisters or large vesicles in the mouth. So pemphigoid, pemphigus, bullous lichen planus, erythema multiforme, and Stevens-Johnson's, angina bullosa hemorrhagica, some viral infections, epidermolysis bullosa, dermatitis herpetiformis. These are the commonest conditions linked with oral blistering. Pemphigoid is an autoimmune condition where the autoantibodies, they target the basement membrane, they attack it. Autoantibodies, they bind with the and they activate the complement, which attract further defense cells, WBCs, resulting in the degradation of the basement membrane, and it separates the epithelium from the connective tissue, and in between that space is the accumulation of fluid, giving a blister. Pemphigus also has autoantibodies form, but they are directed against the adhesion molecules, desmoglin, in the desmosomes, which hold the epithelial cells together, the prickle cells or the spinosum cells together. So in pemphigus, the autoantibodies target the cement between the cells, so it breaks the cells apart. So cells detach from each other, that is called acantholysis, and the space gets filled with the fluid and then the blisters form. So the separation in the pemphigus is within the epithelium in the stratum spinosum. That is where the split is above the basement membrane, and in pemphigoid it is below the basement membrane and the connective tissue. So it is a subepithelial vesicle or blister. It is intraepithelial vesicle in pemphigus. Bullous type of lichen planus, it's also a T cell mediated reaction, again autoimmune. Here also the cells, they attack the basal cells, and that's why basal cell degeneration is a characteristic feature of LP, your lupus, also your what is the third condition? It was lichenoid reaction. So lichenoid reaction, lichen planus, and also in your lupus, you find basal cell degeneration. Basal cells are killed, and because they maintain the basement membrane, the attachment of the epithelium to the connective tissue is weakened. Usually the epithelium becomes thin and ulcerates because the dividing cells have been lost. But in the bullous subtype, the weak basement membrane separates, fluid accumulates, and a blister forms. Again, so in this also, if the blister would be forming, it is your subepithelial, not intraepithelial. Then erythema multiforme is a kind of hypersensitivity reaction triggered by infections like herpes simplex or drug hypersensitivity, and it causes edema and fluid accumulation below and within the epithelium, giving you raised target-shaped blisters. Angina bullosa hemorrhagica, here a blister is formed, which is filled with blood. Then viral infection, like herpes simplex and herpangina, they give you vesicles, and the infected epithelial cells, they lyse to release the virus particles. Clusters of epithelial cells burst beneath the intact surface layers to produce vesicles or small blisters, and which later rupture to form ulcers. They are all intraepithelial vesicles. Epidermolysis bullosa is a heterogeneous group of inherited defects in the components of epithelial cytoskeleton or of the basement membrane. There is mechanical weakness in the tissue, allowing fluid-filled spaces to open up with mild trauma or spontaneously. Dermatitis herpetiformis, autoantibodies are formed against dietary gluten. They are thought to cross-react with epithelial cell enzymes. They bind near the basement membrane. They activate complement. They cause foci of separation of epithelium. Blisters are only small vesicles. They are not usually clinically seen as blisters. Blisters are large vesicles, so not large. Again, by definition, it's herpetiformis. Small vesicles are seen, like in herpetic gingival-stomatitis. So these are the possible conditions that can give you blisters in the mouth. What name is given to the gingival appearance? Well, this appearance is called desquamated gingivitis, and it is characterized by inflamed, peeling gingiva and separation or loss of epithelium. The gingiva appears erythematous, edematous. Unlike your plaque-induced gingivitis, the gingiva erythema also goes to complete width of entire gingiva and sometimes even beyond alveolar mucosa. Patients also report gingival discomfort, sometimes bleeding. So what are the major causes of desquamated gingivitis? Lichen planus, pemphigoid, and pemphigus. So blister-containing conditions are those, plus the ones which will have desquamated gingivitis. So amongst this list, only these top three would be associated with desquamated gingivitis. So these three would be making up to your list of most likely diagnosis here. So the most likely diagnosis here is either your lichen planus, mucus pemphigoid, or pemphigus. Which of these conditions would you include in your initial differential diagnosis and why? So first, your pemphigoid. A good history of blister formation with subsequent rupture makes your pemphigoid as the most likely diagnosis. In pemphigoid, 90% of the patients with oral lesions have desquamated gingivitis with or without additional involvement of buccal mucosa and palate. The lips and tongue are not frequently affected. So pemphigoid is slightly more common in women than in men and often presents after 55 years of age. All the features fit the current presentation. There is nasal membrane involvement as well. There is crusting and bleeding, which indicates that nasal involvement, because nasal, esophageal, laryngeal, and genital mucosa, and even the eye mucosa, they all get affected in mucous membrane pemphigoid. Then pemphigus, approximately 70% of the patients with pemphigus would have oral lesions on presentation, and it eventually involves oral mucosa in greater than 90% of patients. Oral lesions are usually more extensive than in your current patient. There would be ragged, irregular areas of ulceration, which have been derived from ruptured vesicles. Compared with your pemphigoid, pemphigus is less likely to present with gingival lesions alone. It is rare to find intact blisters in pemphigus, and patients often do not notice them because the epithelium of the blister roof disintegrates quickly. Because pemphigus is intraepithelial, again, the roof of the vesicle is formed by few epithelial cells, so it is friable. So patient sometimes does not even notice that the vesicle was formed. And the long history and the absence of skin lesions in the present case also goes against pemphigus and makes pemphigoid more likely. However, investigations are necessary to completely exclude the possibility of pemphigoid, so pemphigus. Then lichen planus. Lichen planus is the commonest cause of desquamated gingivitis and gingival ulceration, but it rarely produces blisters. Most patients with LP have buccal mucosal and lateral tongue involvement, and only 10% present with gingival lesions alone. Erythema and ulceration are consistent with LP, but often features like reticular striations or white plaques are not present in the gingiva of this patient. Occasionally, desquamated gingivitis caused by LP may be associated with genital involvement as well, and it is important to ask the patient whether they have any genital symptoms. In females, the presentation of vulvovaginal gingival LP is associated with significant morbidity and scarring of the affected sites. Although blister formation in LP is rare, when it does occur, gingiva would be a common site. And what diagnosis have you excluded and why? So you have excluded EM just because it is even considered as one of the likely causes because it is a blister condition. Otherwise, the age and the gender, they are not correlating with EM. Age is 20 to 40, it's more common in males. Then diffuse areas of mucosal erythema, painful erosions, they are primarily seen in the anterior part of the mouth. Crusty, bloody lips, buccal mucosa, labial mucosa, alveolar mucosa, and tongue are involved. Skin lesions are also present with a characteristic target-like appearance where there is a central vesicle surrounded by a halo. The EM lesions usually appear over the course of 3 to 5 days and resolve within approximately 2 to 3 weeks, so it is acute in onset. And EM does not give you desquamated gingivitis. Then angina bullosa hemorrhagica. This term is used to describe acute recurrent subepithelial oral mucosal blisters which are blood-filled. They are typically seen in palate, oropharynx, and they heal rapidly. The distribution, slow healing, and the clear fluid-filled blisters in this patient also make the hemorrhagica less likely. Drug reaction, like lichenoid reaction, well, they can give you pemphigus or pemphigoid-like presentation, and this patient is taking then an antihypertensive drug which is implicated with lichenoid reaction. If the presentation were more typical of LP, then a lichenoid reaction may be considered. Then any other rare vesicular bullous condition, those that may affect the mouth can be excluded at this stage, like your dermatitis herpetiformis, which is associated with celiac disease. It gives you mostly skin lesions rather than oral, and oral involvement is rarer, may manifest as small vesicles rather than large blisters. Then epidermolysis bullosa encompasses a clinically and genetically heterogeneous group of rare inherited disorders characterized by marked blistering and erosions occurring after minor trauma. There is often scarring also of the affected site. Other causes which you have eliminated are your viral infections because they are accompanied by systemic signs, and of course the sizes of the ulcers in the vesicles are smaller. They're not large blisters, they're small vesicles, and that's why even your desquamated gingivitis is not linked with them. So these are what you have eliminated. What additional questions would you ask during your history taking and why? You would ask about the cutaneous conditions, cutaneous presence of blisters, because cutaneous blistering would confirm the presence of a systemic, probably an autoimmune disease, which helps in your diagnosis, provides further lesions for investigation. Cutaneous pemphigus lesions are appearing as a flaccid blister which ruptures quickly, resulting in your painful erosions which also bleed easily. Pemphigoid may also present with localized blisters or erosions, which often occur on the face, scalp, arm, or legs. They heal with atrophic white scars. Cutaneous lichen planus gives you pruritic purple polygonal papules or plaques. Target-like lesions are seen in EM, so systemic signs are different for these different conditions, so they should be asked for. Then, do you have any problems anywhere else? Because your mucous membrane pemphigoid involves other mucous membranes like genitalia, nasal mucosa, larynx, anal surfaces, esophagus. Pemphigus can affect esophagus, upper respiratory tract, eyes, and genitals or perianal sites. In this case, no cutaneous lesions are found. History of recurrent epistaxis or bleeding from nose and crusting is suggestive of nasal mucosa involvement. So, what investigations would you perform and what's the significance? So, you would do the biopsy. Let's see what are the investigations: the biopsy and also the serum investigation for antibodies. For biopsy, you would do a direct histological examination and also a direct immune fluorescence examination. For histological examination, you would take a sample and do the formalin fixation. But for the immune fluorescence investigations under the microscope, you would not fix it in formalin, but rather use a transport media like Michael's medium. If you fix it in formalin, then the immune fluorescence would not be possible. Serum should be investigated for your indirect immune fluorescence. So antibodies circulating in the blood are also investigated like that, which would be binding to desmosomes, that would indicate pemphigus. If they are binding to the basement membrane, they would indicate pemphigoid. So that's how you differentiate between pemphigus and pemphigoid. So after the histology specimen was taken and then histology was seen, what do you see? Let's look at the histology. One is simple microscopic histology, another is direct immune fluorescence. This is your subepithelial split here. The basal layer is part of the roof. As you can see, it is part of the roof of the ulcer or the blister, and the connective tissue lies underneath. The split is clearly below the basement membrane, and that's why it is correlating with pemphigoid. Here you see the immune fluorescence. It was corresponding to the IgG antibodies binding to the basement membrane. So it was found on histological features, separation of a full thickness of epithelium at the level of basement membrane was found without epithelial damage. It is consistent with the diagnosis of pemphigoid. Pemphigus is excluded because there is no acantholysis, no damage of intraepithelial cells. The split is also not above the basement membrane or above the basal layer, but rather below the basal layer. So it's your clearly pemphigoid. And even in your direct immune fluorescence, you have found the autoantibodies which were correlating with your IgG. There is no intracellular binding of IgG around the cells. It is only binding to the basement membrane, again correlating with your pemphigoid. Diagnosis is the patient has pemphigoid, of which there are several types. There is no skin involvement excluding bullous pemphigoid, a pemphigoid variant which is predominantly of your skin type. And so the final diagnosis is only mucous membrane is affected, so mucous membrane pemphigoid. How should the patient's condition be managed? The primary goal is to halt the progression and alleviate symptoms and prevent complications. So symptomatic treatment, like using your pain relief mouthwashes, like benzydamine, then topical steroids may be effective alone, but only if the disease is very mild. They are more effective when combined with systemic agents in more severely affected cases. Betamethasone can be given 4 times a day, or clobetasol can also be mixed with your other corticosteroids or with your anesthetic agents applied directly to the affected areas, but they all should be used in secondary care like hospitalization. Immune suppressants like dapsone or your other agents like azathioprine, mycophenolate can also be used. They all should be used in hospital administration, not by your general dentist. This patient requires multidisciplinary treatment, should be referred to ophthalmologist to identify and manage any ocular lesions which may be present but not yet have been identified yet, because that can lead to severe scarring and blindness. Patient may also require referral to ear, nose and throat specialist for management of nasal and laryngeal involvement. Can you manage this patient in primary care? Well, the investigation and treatment options require that the patient be treated in secondary care setting, at least until a definite diagnosis is made and condition has been stabilized. After that, the general dental practitioner has an important role to maintain the plaque and calculus, because that can worsen the squamous gingivitis. But patients who are using systemic or topical steroids, they're also prone to oral candidiosis. That should also be monitored at the subsequent visits. So what are the significant complications, if any? Yes, there are some. Chronic ulceration can lead to varying degrees of scarring. Some patients have disease which may predominantly or exclusively affect the eye. In the eye, there can be scarring, which can lead to adhesions between the lid, conjunctiva, and the surface of the eye. Restricting movement and infolding of the lashes, inflaming of the surface of the eye, ultimately also leading to blindness. So severe consequences can be found with ocular involvement. Oral mucosa is relatively resistant to scarring, but scarring in the eye, larynx, and esophagus may be severe. Patients are also at the risk of getting side effects of steroids and other immune suppressive agents, which would be systemic immune suppression or bone marrow suppression, increased risk for infection and malignancy, oral candidiasis infections. All those should also be monitored, and that can be the complication of not the disease on its own, but the management of the disease. So beautiful chapter. Diagnosis, histological findings, then your management part, the ocular involvement, the multidisciplinary involvement, and the various clinical signs and symptoms. So repeatedly getting asked in the exam, please make sure that you understand this well. Send me the doubts if at all any. I would be happy to help with those. And thank you so much for all your support that you have been providing me with, because of my incapability of taking a live class for the last 1 week almost now. With that, I'll be happy to tell you all that I've been already able to, I've run the first week of my entire viral infection, and I'm into my second week. And usually what's in the news and everything, usually the most severe and the symptomatic stage remains for the first 14 days. I think 100% it is coronavirus only, because I've lost my taste, my smell, my taste, and also it's giving me severe vertigo, because even I think the vestibular nerves are also affected. So the entire A&D getting affected is giving me severe loss of balance and vertigo. I have to sit on my bed and record the session. So I hope by the end of next week, because last Saturday I started getting my first symptoms. So I think by next coming Saturday, the end of this week, I should start recovering and be symptom free at least. So it's not a very severe symptom. You can't say that it's body ache or fever, but this vertigo is actually taking a lot of toll on me. So, but I'm dealing with it. I'm just hoping for it to pass as easily as it can. Fortunately, all of my family is dealing with the mild symptoms and everybody's getting out of it. And I'm taking from the youngest member of our family to the oldest one. Everybody's recovering fine, dealing with it fine. So I'm grateful for that. And by God's grace, we are in the next 1 week or so, we'll be out of it. And if my symptom of vertigo finishes soon, I shall start taking the live session. So I will inform you on Wednesday that whether I'll be able to take the live class or not. So thank you so much for your constant support. I'm really am thankful and grateful to all of you for your wishes and your support to me. I hope you take away a lot from these webinars also, and you're learning constantly. Please keep sending me your doubts. I'll be able to answer your doubts as well. Don't stop sending me your doubts. Please don't do that. And I hope you gathered a lot about periodontitis today, the treatment part, the pemphigoid. It was fun. It was informative. It was learning. Please keep discussing. Please keep talking about these concepts. Please don't think that exam is not happening. I have to talk. I have to read less, or maybe I have to study less. No. Even if it's a little bit of effort that you're putting every day in your studying, it would make a huge difference. So let's keep putting that little bit towards our goal. Even this little contribution that you put every day in your studying would take you great things. It would serve you on a very long run. So continue studying, continue maintaining your zest, and I shall see you guys soon live as well. Have a great day. Please send me the doubts whenever you have any discussions that you want to have. I'll be happy to help you. Thank you so much. Ending this meeting now. Thank you so much, guys.